as it turns out. Courtney Yuen, who's an epidemiologist and assistant professor in the Department of Global Health, Social Medicine at Harvard Medical School. She's also in the Division of Global Health Equity at Brigham and Women's, and an associate director for implementation science at Harvard University Center for AIDS Research. So Courtney has been doing a lot of work on improving diagnostics, TB diagnostics, in work in Peru, Kenya, and elsewhere. And she's here to talk about achieving equity and patient-centered care in TB diagnostic services. So Courtney, it's a pleasure to welcome you. I'm sorry we didn't see you in person, but I know that's totally beyond your control due to our sudden resurgence of winter here. Please go ahead.
Thank you. And I'm also sorry I couldn't be there in person, but freak April nor'easter got in the way of my flight. Okay, so am I projecting my slides properly?
Yes, I can see them well, nicely.
Great. So today I'm going to be talking about achieving equity and patient-centeredness in TB diagnostic services based on my work in Peru. No conflicts of interest. And really what this work is going to be focused on is closing the global gap in TB detection. I think this issue doesn't necessarily need an introduction to this audience, so I'm just going to point out that there is a big global gap, right? Around 30% of people with TB are not diagnosed and treated, and the gap between estimated incidence and case notifications has not really changed that much over time, despite having new and better diagnostics in this period. And there are many reasons for this, and I'm not trying to minimize many of the technological or clinical reasons, but one thing I focus on is the fact that there's a mismatch between the delivery of services for TB diagnosis and the needs of people with TB. So notwithstanding the limitations in those diagnostic technologies, service delivery, I think can be improved a lot to make the most of what we currently have. Just to define a couple of the terms that are in the title of my talk, both equity and patient-centered care have a lot of definitions that one can find. I've just chosen two from the World Health Organization and the Institute of Medicine. Equity being the absence of unfair, unavoidable, or remediable differences among groups of people. And patient-centered care being care that is respectful of and responsive to individual patient preferences, needs, and values. And for anyone who has worked in TB programs, whether that's in low incidence settings like Canada and the United States, or whether it's in high incidence settings in low and middle income countries, I think many of us would agree that both equity and patient-centeredness are lacking in standard models for delivering TB diagnostic services. We know that there are gaps in case detection that affect some people more than others, even in settings where resources are not an issue and there's not very much TB. We know that there's disparities in the diagnostic delays, depending on how much access people have to the healthcare system. We also know that one-size-fits-all services, which are kind of the standard model for centralized TB programs in places with a lot of TB, these models are not responsive to individual needs. So with that lens, I want to introduce the setting of TB in Peru. Peru is an upper middle income country. It has a high degree of wealth inequality. So if anyone has been to Peru as a tourist, you've probably stayed in the Miraflores district, which is shown in the picture at the top. It is beautiful. This is the park that runs along the coast. People go there to surf. I don't think there's any surfers in the photo, but there is a paraglider, which you can see because there's a paragliding port in this park. But in this same giant megacity, you get towns we have districts that look like the one that's shown at the bottom, which is Caravaggio district, which is where I work. And these districts have far less infrastructure, far less wealth. You can see that, as in this picture, much of the infrastructure is not as formal. So you get buildings that are kind of built in places that don't even have paved roads, even though they're in the city of Lima. Peru has the highest TB incidence in Latin America, currently estimated at 150 per 100,000. And the TB epidemic here is not driven by HIV. Peru's general HIV prevalence, I think, is lower than that of the United States. This is not like many of the sub-Saharan African contexts where a large proportion of the people with TB are also co-infected with HIV. Peru technically has universal health coverage. Everybody is entitled to some form of insurance. And the safety net insurance that everybody would be entitled to if they don't have another form of insurance would entitle them to free TB services in the public sector. But despite these free services, there are barriers to accessing the services, including just simple geographic access barriers like the difficulty of travel. So you could see in the previous photo that I showed that a lot of buildings are kind of built up into the hillsides. And so if you live at the top of one of these hills, which is shown in the photo on the top, you would actually have a pretty difficult journey down to a health center, which tend to be built in the more urbanized areas down at the bottom of the hill. In addition to just geography, there are issues with hours of operation that conflict with work or school. So the public health centers tend to be open 8 a.m. to 2 p.m. on weekdays. The larger ones may stay open till 7 p.m., but these hours typically overlap when people would be at work. There are long wait times when you get there, so you'd have to take a full day off of work to go there. And this leads to opportunity costs in terms of lost wages, even if the care provided is technically free. Now, there is a private sector, and people can pay out of pocket for diagnostic services in the private sector, but insurance does not cover this for most people. The organization that I work with in Peru is a Peruvian NGO that is dedicated to bringing high-quality healthcare to communities affected by poverty. They started in the 1990s, focusing on specifically drug-resistant tuberculosis, but have since expanded to have programs in various health areas, meeting the needs of the communities where they work. This NGO is founded on principles of social justice and seeks to achieve that by ensuring that all people have access to high-quality medical care. So before launching into these questions about equity and patient-centeredness, I just want to describe the current situation in terms of barriers to accessing TB diagnostic services in Peru. We did a study about access barriers to diagnostic services and how these barriers were delaying the diagnosis. And if we looked at the patient pathway into care from the point of symptom onset to the point that they first visited a health facility, and then eventually to the point where they got the official diagnosis that enabled them to be put on treatment. And the total time for all of this was, there's a large range, but the median was 9 weeks. And this was, there were delays. This wasn't simply a matter of patients not going to health facilities. The delays were in both parts of this pathway. So between symptom onset and the first visit to the health facility, there was a median of 4 weeks of delay. And the qualitative research we did around this identified both what we commonly think of as patient behavioral factors, like lack of knowledge about TB and perceived lack of susceptibility, And the reason this is important is because many people actually said, well, if I knew I had TB, I would have gone to the health facility immediately because TB is very serious. I didn't think I would get TB, so I thought it was a cold, or I thought it was something less important. And so this feeds into delays in healthcare seeking. But in addition to this, it's not just what we, I think, normally think of individual motivations, but it's also the discouragement that they get from their experience with the public health system. They know that the hours are inconvenient, and they know that there's going to be long wait times when they get there. So this really discourages attendance unless they perceive the health issue to be really serious. Then after the first visit to a health facility, the problem isn't solved. Most patients had to make multiple visits in order to get that diagnosis, a median of 3 visits. And this was because there would be multiple visits required to complete diagnostic procedures if, for instance, your health facility didn't have an X-ray machine and you had to go somewhere else for one. There was also not everybody actually got a TB evaluation when they first got into the health system. And so they ended up either going around and seeking second opinions because they were diagnosed with something and given antibiotics, or it just took the provider a while to order, the X-ray or the sputum tests that would eventually diagnose them. In terms of diagnostic capacity, we did a patient pathway analysis and found that given the places where people typically go to seek care, this being both in the private and the public sector, we estimated that only around 43% of people first go to a health facility that has X-ray. And this is because in both the public sector and the private sector, there actually are not a lot of X-ray machines. On the other hand, more than 3/4 of people first go to a health facility that has smear microscopy, and this is largely driven by the fact that the public sector has made smear microscopy available in all of its facilities. Rapid molecular testing, GeneXpert, is not widely available in Peru as an initial test. It is used as like a follow-up test for smear negative results, but people really are not getting access to that. And this decision is largely driven by costs. For people, this always comes as a huge surprise when I make this presentation to people who work in lower income countries, because they say, when I worked in Kenya, for instance, they scaled up Expert years ago. But the WHO, the negotiated rates for the Expert cartridges don't really apply to these middle income countries. And when you combine it with import tariffs, they're paying something like $20 to $30 a cartridge. So the causes of these delays in TB diagnosis, kind of the problem we're dealing with, is that there are access barriers related to health services as well as patient-related factors that delay the initial care seeking. And then once people actually get into the healthcare system, the services available at that first point of care are often incapable of completing the TB diagnosis. So one of the solutions that I have worked with a lot in Peru is mobile TB screening units. And I'm going to present here not a lot of work about the implementation of these screening units, but more about the looking at whether they in fact promote equity of access to TB diagnostic services. So mobile units are a strategy of bringing diagnostic services into communities. And in this case, we were bringing X-ray services. You can see a picture of one of these mobile units. There's a van in the foreground that has an X-ray machine inside, and then a bunch of tents where people can leave sputum samples, get a clinical evaluation, and then the sputum samples would be taken to the laboratory for GeneXpert testing. So these mobile units, this was supported by a TB Reach funding. These mobile units were really bringing X-ray and GeneXpert into wide accessibility in Peru for the first time. This program also used a lot of community engagement activities to draw people to the mobile units and tried to target these areas that were farther from the health facilities. It screened in the first year, it screened almost 60,000 people, made 393 TB diagnoses, which is substantially higher than the estimated incidence, and led to an 11% increase in case notifications in the districts where it was implemented. So the question is not whether these mobile units can detect TB. We know they can, not just from Peru, but also from other countries. Many of these TB Reach projects have shown that mobile screening increases case notifications. The question that we wanted to ask was, is there actual preferential benefit for people who face those geographic access barriers? Because part of the implicit point of running these mobile units in the way that we ran them was that if you put it in a neighborhood that's far from the health facility that looks like this, then you would be getting at a population that really might be less likely to be able to make it to the health facility, and that would really welcome the opportunity to access their diagnostic service, TB diagnostic services in their community. Whereas if you consider a location that's closer to the health center, which is a more urbanized area where, yes, there's plenty of people on the street walking by, but those people could just as well walk to the health facility. And so, maybe they are less in need of this mobile unit strategy. And the way we looked at this was that we analyzed the programmatic data to ask if people living in those neighborhoods that were farther away were more likely to use the screening units in their own neighborhood than the people who lived near the health center. And we found that that was in fact true, that the farther someone lived from the health center, the more likely they were to actually use the screening unit in their own neighborhood versus one that was somewhere else. The other question we asked around whether these mobile units actually improve equity of diagnosis was to ask, well, who's actually being diagnosed? Because the real goal of an equity-based program is to say we want to diagnose the people who are most likely to be missed by the current health system. And maybe we let the current health system, reach the people whom it's already reaching well. Now, this equity-based approach is actually, if you think about it, somewhat counter to the traditional John Snow epidemiologic approach of going to where you see the most cases. So the kind of traditional public health approach would say, well, if I know that there are certain neighborhoods that have a lot of TB, I should bring services there because there's clearly a high burden of disease there and those people need the services. And while that's true that those people probably do need services and there probably is a high burden of disease there, the converse is not true. If you have a place that doesn't have a lot of TB cases, you don't actually know if it's because there is no TB or whether the people are facing really acute barriers to being diagnosed, and so that there's just no detection of TB. So what we wanted to know was that the way we kind of looked at this issue was we said, if you look at neighborhoods where the mobile unit went, does the amount of TB that the mobile unit detected, is that predicted by the historic case notification rates for that neighborhood? And if the two, historic case notification rates were really predicting how much TB the mobile unit found, then you would say, okay, the mobile unit is maybe just finding the people that are there based on what we already knew about the burden of disease. But if that's not the case, then maybe something else is going on. So we took kind of an agnostic community-based approach to looking at predictors. And yes, we considered historic case notification rates, but we also constructed community-level predictors based on epidemiology, like characteristics of past TB cases, but also demographic and socioeconomic indicators based on census data. And we used some different methods to ask the question of which of these indicators best predict how much TB the mobile unit found, so the diagnostic yield. And what we found was that the historic case notification rates were not the best predictors. And actually, the indicators of lower socioeconomic status were. And we got different indicators depending on what type of analytic method we used, either a logistic regression or a machine learning approach, classification or regression tree analysis. But in both cases, what this is saying is that the decision of where to put the mobile unit is preferentially finding more TB in these places that have lower socioeconomic indicators. And I think these two analyses together are kind of getting at this, trying to demonstrate that these mobile units can promote equity of access. We found that people who live farther from the health facilities preferentially benefit, and that the mobile units may help detect cases in places where there's more underdiagnosis due to access barriers, which is our interpretation of this socioeconomic indicator signal. But this is not to say that mobile units are the solution to all problems. In this experience in Peru, we had a real challenge reaching populations that demographically we know have the highest TB risk. So the majority of attendees at the mobile units are female, and the majority are older. And this is consistent with most health outreach programs, not just in Peru, but I think in many other places where there's higher uptake among women than men. And then the age thing, I think it's just that younger people are more likely to be working, and so less likely to go, even though the mobile units were operating on weekends and during evenings. We also found that there were people being diagnosed in the neighborhoods where the mobile units were working, but they were not diagnosed at the mobile units, they were diagnosed by the health system. And so we interviewed some of these people and we said, oh, did you know about the mobile unit? And if so, why didn't you go? And what we found was, well, a lot of them said, well, I didn't think I had TB, so I didn't go to the TB mobile unit. And then the other issue is one about acceptability, of the stigma of TB, saying, well, I wouldn't be caught dead being seen at a TB mobile unit. So there's that issue of actually missing people, even though they live in that area. And then there's a third issue that over time, as the mobile units went back to the same area, after 2 years, after 3 years, there was really diminishing yield. And I don't think it's because there was no more TB, but I think it's because the population that was going to go to the mobile unit, who found it acceptable and convenient, had probably already been screened. And we weren't reaching the other people. And so this brings me to my second theme of patient-centered services. The mobile unit is good for some things, but it's not actually meeting everybody's needs. So we tried to figure out, well, what would make what strategy or strategies would meet everybody's needs. So we did a type of survey called a best-worst scaling survey, which is a stated preference survey method that helps people rank a large number of options robustly. And we presented them with 9 different service delivery strategies for TB diagnostic services. And those are listed on the left. So mobile unit with integrated screening, so not just TB, but also diabetes, hypertension, mental health, expedited attention at the health facility for respiratory symptoms, home-based screening with a portable X-ray, various variations on the mobile unit theme in terms of location and how it was working, having a pulmonologist at the health center 1 day a week, getting a voucher for a private clinic, etc. And when we looked at, and so on the graph on the right shows in general how these 150 patients ranked these service delivery strategies when asked which of these would have helped you be diagnosed faster. And you can see that so positive values to the right are ones that were preferred, and then the negative values are ones that were not preferred. So the top 3 options in this survey were the mobile unit with integrated services, so not just TB screening, but diabetes, hypertension, and mental health. getting expedited attention at the health facility for respiratory symptoms, so you didn't have to go through those really, really long wait times, and home-based screening with a portable X-ray machine, where a team would bring a backpack X-ray into your house and do the screening there. And one thing that I think is important is that these three represent three different points of healthcare delivery. One's in the community, one is at the health center, and one is in the home. A second important point is that each of these had their people who liked them, and each of them, except for the integrated unit, had people who really didn't like them. So people are different, some people really like, just because there's people who really like something doesn't mean that everybody really likes that thing. And then the third point is that if you just look at these percentages in green of the percent of people who really strongly preferred that strategy, each individual one is not that high. So this is less than half the population. But if you look at the set of all of them and say, what percentage of the population strongly preferred one of these three, then you could actually cover 80% of the people who are being diagnosed with TB. So I think what this shows is that different people want different things, and you can't, and there probably isn't a magic bullet service delivery strategy that everybody is going to like. And so this principle of patient-centered care, we need to be prepared to deliver care in a variety of ways to meet those needs. So in terms of why people had these different preferences, we didn't see really, we looked for kind of latent classes or looked for factors associated with different preferences. There were some things that came out in terms of demographic associations, but nothing very, like no smoking gun saying that, oh, this is how we get this particular group. When we then asked people, though, why did you pick certain things or not pick certain things? One thing that came out really strongly was this fear of stigma and discrimination. And while lots of people feared stigma and discrimination, they saw different modalities of delivery as being more risky in this sense. So what I mean is that some people said, oh, I wouldn't go to a TB screening unit because I don't want my neighbors to see me. But other people, while inviting a team into my home, that would be okay because it's discreet. But other people said, like, no, I don't want anybody seeing me inviting a screening team into my home. And then some people specifically mentioned, well, I'm not going to take a voucher to the private sector because the private sector doctors are going to discriminate against me. They'll think I'm a poor person that I can't pay, and they'll see me last. They'll see all the people paying cash first. Our qualitative research from that the diagnostic delays project study also reinforced this, where a woman who had recently been interviewed about her pathway to care said, in general, people will not go to the screening sites because of shame, because I felt ashamed going to the health center. So I think addressing this, coming up with ways of offering services that really try to address this fear of stigma and discrimination is really important. And so based on this, and based on the results of that survey that showed that this integrated screening program was one of the most preferred, we decided to pilot this because we already had the mobile unit platform. And we said, well, what if we convert the TB mobile unit into a general integrated health campaign unit? So you can see that in this photo that the sign on the left says, it doesn't say TB, it says integrated health campaign. And it offers screening for TB, but also for diabetes, hypertension, and depression. And in this particular setting, diabetes and hypertension are very common and not stigmatized. So, and people are generally interested in diabetes and hypertension screening. So we tried piloting this and we screened 1,000 people. We found a similar, slightly lower yield of TB compared to the TB only mobile units. But it wasn't actually markedly different, and which we kind of were afraid it might be if the if the diabetes and hypertension screening started drawing a much older population, for example. The other thing to note is we found a substantially higher burden of the other conditions, especially depression, which is completely unsurprising given how common they are. But it is just a point that for people who think about TB all the time, we are happy if we find 1 person out of 100 who has TB in a screening program. But these other conditions, you're finding many more times, tenfold that. And so you're actually linking many more people into care. And I think this also drives community perceptions of the screening program because they're actually seeing that lots of people are actually benefiting from this. Anecdotally, the field team said that, if participants were wary of being seen at any of the stations, it was the TB station. They didn't want to go and get the chest X-ray. But they were somehow okay with, seeing a psychologist under a tent in the middle of the community, which really surprised me. But I think this gets at the fact that maybe these are people who might not attend a TB-only screening, and so maybe we were actually reaching a different population, although we don't have hard quantitative data on this. So the third or the final kind of strategy that I want to talk about in terms of patient-centeredness is, well, if patient-centered care means adapting your service delivery to people's preferences, then I think we have to think about the private sector. And I know that for anyone who works in India or Pakistan, other South Asian countries, you've been thinking about the private sector for years. For people who work with TB in Latin America, it really has not been, like if you look in the literature, I think I managed to find 1 paper that was about engaging pharmacists. TB treatment is exclusively in the public sector. And so I think it's just been a blind spot of thinking about diagnostic services in the private sector. But we found in our study that 42% of patients in the study we did on diagnostic delays first sought care in the private sector. And this is a study that we did only in Carvalho district recently. But that result is incredibly consistent with a now decade-old study that was done with patients in Lima, but from 19 different districts, and that found a very similar pattern of healthcare seeking behavior. So we think that this is probably general and durable over time. There's a lot of people who use the private sector and who have TB. Actually, when we did a case control study to look at, to compare people with TB to basically their low risk neighbors, their TST negative neighbors, we found that it's possible that people with TB actually may use the private sector more than others. This was not a statistically significant result, but it was a trend in terms of just this usage didn't seem to be as high in the TST negative people. So this result, but also the case control, what this might suggest to you is, okay, well, if their first point of care when they have symptoms is to go to a private sector, then shouldn't we just engage the private sector to help diagnose TB? Because right now, since the private sector cannot treat TB, they have very little incentive to diagnose it. And we know that there are, far from the patient pathway analysis that we did, we know that there are just far more private sector facilities than public sector facilities. I mean, if you count even just the 1-room doctor consulting office as a facility, there's many more private sector providers, I guess I should say. And we know that some of the larger private sector facilities have X-ray machines, although not a large percent. But still, just given their number, you might think, okay, well, can we at least engage these private facilities that have X-ray machines to try to make up some of that gap that exists in the public sector? And there have been programs in South Asia for private sector engagement to try to encourage private sector doctors to facilitate the TB diagnosis that have proven successful. So, this is something that I think we are thinking about. Could that work in the Peruvian context? And in thinking about this, what we wanted to, while we think this might be patient-centered in a way, because it would be meeting patients where they want to go, we were concerned about equity. Because the question is, where are these private sector facilities, and whom would it benefit if we engaged them in a way that was intended to expand access to diagnosis? So we did an analysis to look at this question for this one district. And we did the thought experiment of saying, okay, let's say we know where all the public facilities that have X-ray machines are. And through our patient pathway analysis, we'd mapped out where all the private facilities that have X-ray machines are. So what if we somehow engaged those private facilities to make the X-rays free, or to encourage them to give free X-rays to people with symptoms or something like that? And we wanted to know, how would that change accessibility to X-ray? So we used an approach called a two-step floating catchment area analysis, which is used for looking at the level of access to a certain healthcare service. And what it does is it compares the population that is using a service, the distance people live, so the geographic accessibility, and the amount of that service that's available in a particular area. And when you combine those, you get a spatial accessibility index, which is higher if there is more of that service per unit population, and it's higher for people who live closer, if people live closer to that service. So we calculated the spatial accessibility index using this method, first considering only the public sector, and that's the panel shown on the left. So there's 4 public sector facilities that have X-ray machines, and you can see that there are kind of the parts in blue are people who live within a reasonable distance of those facilities, and the parts in white are people who don't. The panel on the right adds in the 3 private sector facilities in this district that have X-ray machines, and then recalculates this accessibility index. And so you can see that the impact is, well, there's the section in the middle whose public facility doesn't have an X-ray machine, but they have a private facility nearby that does. And so there's a whole group of people that all of a sudden would get access to chest X-ray if that private sector were made free for them. But you also see that in the lowest portion of this district, you have private facilities that are in this urbanized area that already has a public facility with an X-ray machine. And so access is increasing for people who already had access, and it's not increasing for this group up on the northeast part of the map who still lack access, regardless of whether you consider the public or just the public sector or both the public and the private sector. And so what's happening here is that considering the private sector does increase overall access, you can see that the colors overall get darker, but it also exacerbates disparities because people who were okay to begin with now have more, and people who had nothing to begin with still have nothing. You can see that quantitatively if you look at the median spatial accessibility index and the interquartile, the width of the interquartile range. Now, the actual units are not necessarily meaningful, but if you just look at the comparison, you can see that it goes from, the median goes from, this is the median by census tract, goes from 11.4 to 18.9. So overall accessibility is increasing, but the interquartile range goes from 21.2 to 43.4. So the gap between those who have and those who have not is widening. So I think what this means when in the context of patient-centered care and equity is that we know for patient-centered care, We know that people with TB differ in their preferences and their healthcare seeking practices, and it's unlikely that any single strategy is going to be equally effective for everyone. And so we really need a combination of approaches that appeal to different groups of people. But not all strategies that improve access do so equitably. And I think it's important to have this equity frame in mind when planning the interventions. And I'll be the first to admit that, I have not always had this in mind when planning. And some of these analyses are now making me think differently about, what interventions we want to do. So in conclusion, I hope I've kind of illustrated some of the ways in which, despite free services, people with TB still face barriers to prompt TB diagnosis, that mobile screening units can increase equitable access to diagnostic services, and they're a very useful approach, but they're not a silver bullet, and that a combination of simultaneous approaches to delivering TB diagnostic services is required for patient-centered care, but that when choosing approaches, it's important to consider the equity of potential benefit so that we avoid exacerbating underlying disparities in healthcare access. In terms of what I'm interested in working on, I have an ongoing study also in Peru that's actually trying to quantify different access barriers and model the most impactful interventions for reducing diagnostic delay. So when I say different access barriers, this encompasses, both the economic aspect, the geographic aspect, the convenience, the acceptability, the stigma and discrimination, and seeing what's really driving what's driving people's behaviors, and can we actually model out what the most important things to address are. And then in terms of future research, I really am interested in this question of private sector engagement, but I want to be able to do it in a way that doesn't exacerbate existing disparities in access. I'm interested in models for delivering integrated primary care services that include TB, because I think this mobile unit, we built so much of this TB screening machinery, and then when we actually did this integrated screening pilot, we realized the power of bringing much more healthcare to people than just focusing on TB. And in terms of equity, I think as a field, it would be good to have ways to actually measure equity in TB service delivery. I think a lot of the analyses I've shown are kind of trying to get at it in different ways, because there is not a way to say, okay, this is the metric for equity, and we can apply that to our programs. Yes, we can retroactively measure disparities in outcomes, but that's not really necessarily the same thing. For one, you can't do it beforehand. So thank you very much. I'd like to acknowledge lots of people, especially in Peru, as well as my collaborators in Boston and my funders. Thank you.
Great. Clap, clap, clap. Great, thanks. That was terrific, Courtney. So I see Sammy has his hand up already, so maybe go ahead with a question. And I see, I can't tell. Some people are applauding and some people have their hands up. Okay, so Sammy.
Can you hear me very well?
Yes.
Yes.
Okay, just thank you very much for your presentation. It was very interesting. Well, I am from Colombia, so the situation is quite similar. And I just wanted to ask you about your experience with X-rays. I was involved in a very similar project in active case finding in Central Africa, using artificial intelligence to analyze X-ray. However, the test was not very sensitive. It often says, okay, the result is positive, but then we did GeneXpert and it was negative, and vice versa. So I just wanted to ask about your experience. And my second question, it will be, we actually have many problems, many concerns in terms of the environmental conditions. In so many cases, we didn't have electricity, energy. So if you have just probably any solution to this concern, because of course it's necessary in countries where the incidence of TB is high. So I just wanted to know your opinion in this topic.
Yeah, so this mobile screening unit, like many others, it did use artificial intelligence for the triaging of the chest radiography. We used the CAD for TB program, and we purposefully, well, we did an assessment and we set the threshold to be low, meaning that to maximize sensitivity. So we were willing to test a lot of people to try to not miss people. Now, in terms of like specificity, or saying like, well, if it's abnormal, it's often not TB. Yes, that is the case. It was designed as a triage program, and so that's all we expected it to do. We were not expecting the program to make diagnoses. And I think that's kind of reflective of the state of the field. Maybe with the great advances in AI, AI may be able to eventually make an actual radiologic diagnosis, but all of the abnormals we actually had a medical doctor reading to be able to make the clinical diagnosis. In terms of the electricity, there was a generator. I mean, same issue. Lots of these places there was no electric hookup, so there was a little diesel generator that could power the X-ray machine. And then some of the later programs, they actually got these ultralight X-ray machines that could run on batteries and charged batteries.
Thank you.
Petra, go ahead.
Thanks so much. Thank you so much for this presentation. You spoke to my daily work challenges, questions in every slide that you touched upon. So I really appreciated the presentations overall. Specifically on the public and private sector, particularly the private sector, I had a question for you. I love the spatial work that you did and showing the mapping. And I was wondering whether you had looked at the areas that were underserved, whether there were any private facilities or private doctors that did not have X-ray, and whether placing an X-ray there or engaging them in a way that they have potentially specimen collection through transport mechanisms, or in another way, if there would be a private provider that can be engaged in another way. Have you looked at those data? Because that, I think, is an engagement model that we've seen in Pakistan and many of the Asian countries. And I would finally just conclude that I would love to follow up with you on a lot of these future questions that you have, because they're fully in line with the questions that we are working with in the Learning Network. So thanks.
Yes, that's great. I would love to follow up, especially about the private sector thing. Short answer is no, we didn't map them all out. So I think that is something that we want to do if we're going to try to do a model of engagement and ensure that it actually increases access equitably. Bez.
Hi, Courtney. Glad to see the talk finally happening after a pandemic stalled it. That was really appreciated your talk. One comment and one quick question. The comment was appreciated your contextualization of patient-centered care. And it's interesting to see some of the challenges that you described are analogous to what is seen in the northern part of Quebec in the Inuit region called Nunavik. And there's a couple of people who work there who are on the line who might be better able to comment. But one of the things that we've done in the last 3 years is a sort of a survey of Inuit across the region, where an Indigenous team interviewed 160 Inuit in Nunavik. And our analysis of sort of the responses and about people's experiences with TB in sort of iterative analyses with communities and stuff really reflect this notion that TB care is not patient-centered here, and that's a big move to try to shift those things. So very interesting to see analogous kind of perspectives coming from Peru. So my question is about the mobile screening. If I understood correctly, it seemed like it worked for some people, but I was wondering if how large was the scale of the screening campaign, and were you able to see if it added a significant increase the yield of cases detected. I mean, in Pakistan with IRD and Indus, they seem to suggest that it really added a lot of cases when it was going on. Now the program's been kind of shut down. So I'm wondering if you think it did add a substantial yield, and is it a worthwhile intervention and pursuing in places of high incidence countries?
Yeah, so yes, we did. I mean, the scale, we can only aspire to IRD's scale. They actually helped us, helped with the blueprints for the van and everything. This program only had 2 vans. It screened 60,000 people in a year. It continued for, well, it was basically, it then got kind of shut down by the pandemic and then resumed after. During that initial year, there was an 11% increase in the case notifications associated with where it went. So it's statistically significant. So yes, I think it makes a difference. I think if the program were larger in scale, it would have made more of a difference. However, I do think there's a ceiling to it, because just in that second and third year, as you could see that when it went to places it hadn't been before, there's a bunch of TB diagnoses, but when it went back to the same neighborhoods where it had been before, they would just stop diagnosing people. People would come, but there weren't any more diagnoses, or just people wouldn't come. And so I think that, I think there's probably a chunk of the population that is going to go to a mobile unit, a TB mobile unit. And once you diagnose all the TB in that chunk of the population, then the question is, and I'll say that in those particular areas, the number of cases in the health centers have come down to about half of what they were before that screening program. So I think it's probably mopped up a bunch of people, but it's stable now. And so the question is, who are those people? Who are those people who are still getting diagnosed in the health center? And I think a simple answer is they're people who don't go to the mobile unit, because we're not catching them there, and yet they're being caught at the health center. So I think it means that, I don't think it means that the mobile unit is bad. I think it just means that either you have to start changing your strategy so that you're actually getting different groups of people, or you have to start using different strategies that are complementary. Because I think just different people seek care in different ways.
Thanks, Courtney. So I wonder if I can ask a question that's related to, it's kind of interrelated between costs and, all the other health problems. Because I really enjoyed the talk as well, and the careful analysis of all these, preferences and values. But I did note that, one's clearer preference without almost nobody really disfavoring it was the integrated clinic. I know you started to try that, but so the first question is, what was the cost per person screened for those mobile clinics, especially when you were doing just the TB screening? And the other is, in the long term, is the Ministry of Health going to adopt that? Or would it be more likely to adopt something that is a more general health screening? Yeah, go ahead.
Yeah, so we did not do a costing analysis of the mobile unit, so I don't have an answer for that. I did do a back of the envelope calculation costing for comparing the TB only model to the integrated model. And this was more, actually, it wasn't for publication, it was for budgeting. It was for to help the NGO decide kind of, or figure out what was going on. And what we found is that, the devil's in the details of what your output is. So in terms of cost per, adding on the additional parts for the integrated screening was really marginal cost, because what's really expensive is expert and chest radiography, like a blood pressure cuff and a finger stick hemoglobin A1C are quite cheap. And yes, there's some additional staffing, but you've got so much of the staffing already there that it's incremental. So you have slightly more costs, but your screening volume really goes down, because the TB screening program could screen like 150 people a day in one mobile unit. Whereas this integrated screening unit, they could get half that, if they were, or less than half that, because it took, some people have to actually go through multiple things, including a depression screening, which involved, which could never be done quickly because people really wanted the mental health services. So that's kind of perhaps a contextual detail. So you have this trade-off. If your metric is, but on the other hand, you get lots more people who are diagnosed with potentially having health issues that they need care for. So if your metric is people linked to care or people who get put on a treatment afterwards, it comes out to be much cheaper to do the integrated screening. But if you say, oh, well, hypertension is not as important as TB, like if you start, so we didn't do like a DALY, analysis. So I think it all depends on how you look at it, and how you look at effectiveness. In terms of your question about the Ministry of Health, I think a lot of that has to do with funding streams in these countries. Like, the Ministry of Health did scale up the mobile screening unit because Global Fund funds TB work and allowed them to purchase 30 X-ray machines. Now, would Global Fund allow them to build mobile clinics, to actually bring primary care out into communities that include TB screening, but also include other things? I don't know. So I think in some ways it's, I do think that an integrated mobile clinic is actually more consistent with what the Ministry of Health does for community outreach campaigns. But the question is where the money's coming from, right? And who's willing to fund what.
Yeah, no, I think that's it. It's, kind of all of these, kind of active case finding activities, they demonstrate yield, but then the question is who's going to pick up the ongoing cost to do it again and again, if there's some benefit of doing it again and again. I guess the other question is whether you thought that some of the population missed was just, again, related to work hours and so on.
Yeah.
Could it be because you had mostly women and older? So
Definitely. I mean, we tried so hard. We had so many community engagement efforts around trying to get young men to come. We tried like a version, it's not like responded driven sampling, but one of those things where you give people vouchers to give to their tickets to give to their friends, and they would get a little like bonus if their friend came. And we tried and working with like sports clubs and like different, and we tried asking, men, like the partners of the women who came, like, why are you not coming? Okay. And it's just, they're like, I work 6 days a week. I have 1 day off. Yes, I know that the mobile clinic is there on Sundays, but there are things I'd rather be doing on my Sunday. So, I don't know. So actually the places that we found the most, that we were able to engage the most men was working directly with the employers. But that works for a certain segment of the population that is formally employed.
Yeah. Okay.
So,
interesting.
but I think this is a larger problem than just TB. I know like HIV has the exact same problem.
Yeah. Great. Okay. Thanks. Okay. Well, it's the 2 o'clock. Everybody's outlook is now reminding them to go to the 2 o'clock meetings. So Courtney, really thank you on behalf of everyone. Really great talk. Very interesting. Food for thought, as Yasin said. So yes, applause from everyone, and thank you. And we'll try again for a future visit.
Thank you. Third time's the charm.
Third time lucky. Yeah.
Okay.
Great. Thanks again.